my great pleasure to introduce some of the wonderful folks who are making the Sonoma West Medical Center, often referred to these days as SWMC. You saw all those red placards on the way out to the beach about Save Our Hospital. Raymond Hino is the CEO of SWMC and the new hospital in Sebastopol, located on Palm Drive Hospital, as everyone knows. He brings 35 years of hospital management experience to this new institution. Michael Collins, good morning, is an amazing person. As interim chief nursing officer of SWMC, he has taken the entire clerical staff under his wing. He has done just about every job in a hospital that a person could do. So that's Michael Collins in the middle. And then I had the great pleasure of talking with Jane Rogan-Dwight, who is the marketing director for SWMC. And she is here on behalf of Dr. Alan Bernstein. Many of you know the good doctor who talks eloquently and up-to-date about Alzheimer's today. She'll discuss the new memory loss research program, and I've been distributing these flyers to all of my clients. Please, if you can, register for this wonderful healthcare registry. It's a great idea. Dr. Bernstein is really onto something. So would you please put your hands together and welcome the SWMC team. Thank you.
Good morning, everybody. As Chance said, my name is Raymond Hino, and it's a great pleasure to be here this morning with all of you. I've been on board now for almost a year. I was hired and began the first week in November in 2014, specifically by the Palm Drive Healthcare Foundation at that time to open the hospital. I am originally from Southern California. I first became aware of Palm Drive Hospital and all of our fine hospitals in Sonoma County when I worked up in Mendocino County for 6 years. I was previously the CEO of the Mendocino Coast District Hospital up in Fort Bragg for 6 years from 2006 to 2012, and came down here frequently. Of course, we always shopped in Santa Rosa. We're very fond of shopping in Santa Rosa, but became very familiar with the hospitals. And last year, I was contacted and asked if I would have an interest in heading the effort to reopen the hospital. And it was mentioned by chance, all of the red and white signs. That had a big impact on me. When I came out to the area to take a look, it's very difficult to reopen a hospital once it's closed, and that's going to be my topic for the next few minutes before I turn over the microphone to Michael Collins. My topic has to do with the challenges of reopening a hospital once it's closed. But when I saw all the red and white signs and saw the community support, met with people from the community, I thought, this really has a chance. Because it takes a huge effort. So what we have done and what we've accomplished over the last 8 months is we have brought our hospital to the very brink of reopening our doors. We actually expect, and if you've been following the story and following the news, it has been kind of frustrating because we've been saying for several months now that it looks like our hospital is going to be open soon, any day. And we're continuing to say that, but we inch forward closer and closer every day, and now we truly are very close. We just received our documented written findings from the state of California, those things that they are requiring us to do in order to reopen the hospital. We just received those written findings last Friday. The next step is that it's our responsibility to document for the state our plan of corrective action on what we propose to do in order to reopen the hospital, or to meet all of the state requirements for a licensed hospital, I should say. We plan to have that in hopefully by today. Once we get that report in, it'll be up to the state to either accept or reject our plan of corrective action. I am anticipating that they will accept our plan of action. There will be one last final survey to make sure that we meet all the regulations, and then following that final survey, we will have permission from the state to reopen our doors. So it could happen very, very soon. The journey to get here started with last December and January, the process of bringing the hospital back to licensure status. When the Palm Drive Healthcare District closed the hospital on April 27th of 2014, they did one thing that has been extremely helpful to us. They did not surrender their hospital license. What they did was they kept their hospital license intact. They continued to pay their licensure fees. They moved the 37 beds in the hospital from active status to putting them in suspense. By putting those beds in suspense, they did us a huge favor in reopening the hospital. It meant that all we had to do was to meet the current state regulations in order to open the hospital. Had they surrendered the license and surrendered the beds, then we would have had to start from scratch as if we were a brand new hospital. As if we were the brand new Sutter Hospital, for example. We would have had to prove that the hospital itself met all of the current regulations for changes in hospital building construction that have taken place over the years. We don't have to do that. The building itself is deemed to be compliant. That doesn't mean that there weren't significant challenges with the building. Those were the first challenges. When we were informed that, and when we informed the state that we planned to reopen the hospital, the state informed us that the first thing that we had to do was to bring the hospital up to the earthquake seismic requirements that were passed by the legislature back in the 90s. Back in the 90s, the legislature passed a series of laws and bills that said that all hospitals had to be brought up to current earthquake building code compliance, starting in the 90s with several milestone dates continuing on to the year 2030. That's one of the reasons why Sutter Hospital had to build their new hospital, by the way, if you're familiar with that story. Their old community hospital did not meet the earthquake seismic requirements, and the only way for Sutter to meet those requirements was to build a new hospital. So that's one of the reasons why they did it. Fortunately for us, the Palm Drive Hospital does meet the structural seismic requirements, but did not meet the non-structural requirements, and they were supposed to be completed back in the year 2002. So the state said, we're not going to grandfather you for compliance with earthquake requirements that were supposed to be completed in 2002. That meant that we had to replace the liquid oxygen storage tank system. No small task. A 500-gallon liquid oxygen storage tank had to be replaced. We had to re-anchor the emergency generator, and we had to re-anchor emergency lighting. Along the way, we found other problems with the building as well. It is a 40-year-old building. The Palm Drive Hospital was built in 1975. So we found the air conditioning units on the roof of the building had never been replaced in 40 years, and they were non-functional. We opened up some walls to gut the pharmacy and build a new pharmacy. We found mold in the wall. So we had to mitigate the mold in the wall. We had to replace the air conditioning units on the top of the building. It took us until July 6th of this year, 2015, to bring the hospital up to all of the building code requirements. And we were fortunate in that regard. We only had to do the earthquake, and we had to do some of the basic building requirements. As I said a moment ago, we didn't have to build it as if it were brand new 2015 construction. But July 6th, we got approval from the state from the Office of Statewide Health Planning and Development, OSHPD, for the building construction requirements. Then we notified the State Department of Public Health, CDPH, that we're ready for our licensure inspection. CDPH has been working with us. They've been great. What they said was they were prepared for us for our licensure survey, but the earliest that they could get a full team together to survey us was July 27th. On July 27th, we were visited by a team of 6 professional surveyors. They included 1 doctor, 1 pharmacist, 1 registered dietitian, 1 medical records professional, and 2 nurses. And for the next 3 days, they went through the hospital with a fine-tooth comb. At the end of 3 days, they notified us that we had passed the survey in all but 4 areas. The 4 areas that were not passed on July 29th were pharmacy, dietary, infection control, and preventive maintenance. And there were a few findings in surgery as well. So we informed the survey team that we wanted them to come back as quickly as possible and complete the survey. They came back the following week on August 6th, and 6th and 7th, and they passed us for infection control and preventive maintenance. They came back the following week with a registered dietitian who was supposed to be in our facility for 2 days on the 13th and 14th, and she passed us after 1 day and said, we're ready for our food service, dietary department, and said that we were ready for the survey to be over with, and we all agreed with her. Then we told the state that we're ready for our pharmacy inspection, the most difficult and most onerous of all of the survey. We got our pharmacy license on August 10th. We started stocking drugs in the facility on August 13th. The state informed us that they were coming back for the pharmacist survey on August 31st. On August 31st, we were visited by 4 surveyors, 2 pharmacists, and 2 registered nurses. The 2 registered nurses were there to finish the surgery survey. The 2 pharmacists were there to survey the pharmacy. The 2 registered nurses finished after 2 hours and said that there are still some small minor findings in the surgery department, but that wouldn't prevent us from opening the hospital. The pharmacy survey was much more rigorous. After 2 days, the pharmacist left, and we received a phone call from the state that said that we're now to the point where we need to document the formal status of your survey on a form 2567. They told us verbally what their findings were. There were 5 small findings in surgery, 15 findings in the pharmacy department, all of them easily correctable. And we said, we will take care of the 20 findings, and we want you to come back. So where we are today is where I started my talk this morning, is that we received the formal written report, the 2567, on Friday last week, 9/11. We intend to turn it back to the state today with our plan of corrective action and invite the state to come back and survey us one last time to open the hospital.
Very good.
Been a long road. We're almost there. So now I'm going to turn it over to Michael Collins, who's going to talk about care for our senior patients at Sonoma West Medical Center.
Thank you, Ray. Okay, well, as they said, I've done pretty much every job in the hospital. I've started off as a unit clerk, and then became a phlebotomist, then a blood gas technician, then a pulmonary tech, then a respiratory terrorist. And if you've ever had respiratory therapy, you know it can be brutal. Then decided I needed to go to nursing school. So went to nursing school at the SRJC, became a nurse, and then got my master's in nursing, and now I'm here. I worked at Palm Drive, gosh, 20 some odd years ago. And so it's kind of a long, big circle for me. And I'm very happy to be there. And what we're going to be doing for our elderly population, which is a very significant amount, in Sebastopol and that surrounding area. We've got a lot of great doctors and institutes that are joining us. An institute of ortho, and one of rheumatology, one of urology, one of brain and spine, endocrine system. So it's a very, we've got a lot of great professionals. And we're training our staff not to do what we've done in the past. Now the Old Palm Drive had a stellar reputation for care, and a lot of those same professionals came back. So I anticipate that we'll maintain that high level of professionalism and excellent care. But one of the things that we're getting away from is what I would call age discrimination. And that is where you look at the elderly population not as patients or anything else, but just as old people, if you will. A good case, in fact, would be you get an elderly woman that comes in with some mental status changes and maybe fell or something like that, and she comes in with a urinary tract infection. And in the past, it's always been, well, that's what we expect. We just expect that if you're an elderly woman with a UTI, that you're going to be confused. And we just say, oh, that's normal. But what we're training our staff to do is, at the onset, figure out why are they confused. That's just one stage of it. And then we go down that road and we find out that they're actually in the beginning stages of sepsis. So we're going to be very aggressive with that, with looking at our patients as soon as they come in. If they've got a diagnosis of dementia, well, let's find out how bad it is. Let's look at them as a patient first, and then look at, all of the things that may have contributed to their current problem. Because when you get older, as you know, as I'm certainly learning to find out now, I got my AARP card just recently, so so I can count myself as a mature person now. We'll just use that word. But there are a lot of things that can contribute to any current problem with a patient. A good example of that would be pain medications. A lot of times we don't treat them appropriately. We either underdose or overdose. And by overdose, what I mean is that if they've got heart failure, it may take a while to circulate those pain medications throughout the body. So what happens is it kind of pools, and we give them more, and we give them more, and then all of a sudden it hits them all at once. Well, that can be a big problem. That can also be a problem because that increases the risk of falling. So we're going to be looking at our patients, like I said, as patients first, and people, not just patients, but I guess people, because they do have a life story, and that life story, a lot of people, they've got a lot of experience, and we would like to hear about that experience, because it tells us a lot about that person and that patient. So we can focus our care on the patient and make it relevant to them. It also helps if you know more about their past and their life. It helps to center them if they do have dementia or Alzheimer's. It helps to center them where they are so that they don't degrade much further. We're trying to keep that at bay while they're in the hospital. Trying to think of the other things. I talked about the increase in fall, the symptoms of stroke. We're going to be ever presently watching for that as well. As soon as anybody comes in, they're going to be evaluated for a lot of different things. And that's one of the great things about our emergency room, is that we are basing it with Dr. Rodney Look, who had started a program of a 5-minute wait in the emergency department. And when I say 5-minute wait, if you've been in the hospital recently or gone to the emergency department recently, like my Grammy, she had a suspected stroke, turned out to be a TIA. She went to one of our facilities here and spent 23 and a half hours in the emergency department before they moved her to her room. And it was only when I reminded them that, okay, well, you know what, you've got maybe like 20 minutes more, and then you're going to pay about $10,000 fine because you can't keep a patient in the emergency department over 24 hours. And they were pushing on that very quickly. In fact, all of our emergency departments are overburdened. Now, what is going to make our department a little bit different is we've got a vertical care wing. So what's going to happen is the patient is admitted and they go into vertical care if they're stable. And these are chairs that can very quickly be converted into gurneys. So if they need to move somewhere and be admitted, we can do that very quickly. So we get their vitals and we get their history and stuff like that. And then the physician comes in. The physician can see that. We do everything on tablets now for the most part, so we're charting at the bedside. If you remember other facilities, they have what they used to call COWs, which are computers on wheels. That's a great idea, but the problem with that is that many times, I've worked at Memorial, Sutter, and Kaiser here, a lot of the times when you're in the patient's room, you're not talking to the patients. You are getting their history like this, and you are turned away from the patient. That is not engaging that patient at all. In fact, it's kind of rude. You're not talking to them. You're just like, while you have your attention on that. This way, we can actually type and get an idea of what's going on, looking at their expressions and getting more information in a very succinct manner. The other good thing about tablet charting is that if they have a wound or anything else, we can take a picture of it right there on the spot, and that goes in the patient chart. But as far as the 5-minute wait in the ED, that's about how long Dr. Look has a track record over at St. Helena. That's where he started this program, and he's bringing it to us now. And the average wait is 5 minutes, not 5 hours, not 50 minutes, not 5 days. Down in Southern California, in Antelope, I think, when I was teaching down there, they had patients in their emergency department for 3 days, which just blew me over. I could not imagine having to stay in the emergency department for 3 days. So to wrap it up, basically, like I said, we're new. We're the new kid on the block, but we also have a lot of experience. We've got experienced doctors, we've got experienced nurses, and we're going to do the latest and greatest in technology with the tablet charting. One of the other things is we've got a 3D mammography machine so that it can catch some of the subtleties that a regular mammogram might miss. So we're going to be able to do that. We've got our institute, we've got Dr. Bernstein, as Jane is going to talk to you about. And we've got the orthopedics, Bollinger is a great one. In fact, he does something that's different. If you're a medical person, you'll understand. If you're not, it'll be new information. Rather than do a lateral approach for a hip replacement, he does an anterior approach. It doesn't require as much pain medications, and you're up on your feet a lot sooner. And the healing time is much quicker because you're not going through a lot of muscle. So that's something that's very great. I think he does that, and he's one of the few in the North Bay area that does it. So we're really excited to be opening and being able to serve our county, because a lot of our patients are going to be our neighbors or our family or our friends. And I would like to think that we would treat everybody as our family or our friends. Assuming, of course, you like your family. Not everybody does. But if you're on good terms with your family, we will plan to treat our patients like family and friends. So thank you for having us. And I'll pass the mic on to Jane now.
Thank you, Michael. Right here. Hello, everyone. I'm Jane Rogan-Dwight. I'm the marketing director. And doctors have busy schedules, so we were hoping Dr. Alan Bernstein could come talk to you a bit about his memory loss research project, which is very exciting. But you get me. So I will do my best here. Dr. Bernstein is a nationally renowned neurologist. I'm seeing people nod in the audience. He is well known in the county. And he's known particularly for his stroke care services. And we are very fortunate to have him as part of our institutes. You've heard us talk a little bit about the institutes. And I'll just clarify that a bit. So we have Sonoma West Medical Center, which is the hospital. And we have Sonoma West Medical and Surgical Institutes. They're right across the street from us, and we are very, very closely aligned with the institutes. And Michael told you some of the services that we will be having there. And Dr. Bernstein will have his Stroke Care Institute there as well. But what is newer ground for him is his foray into the broader aspects of memory loss disorder. And of course he was familiar with that because about 1/3 of our stroke patients do suffer some kind of memory loss. But Dr. Bernstein became associated with UCSF's Brain Health Registry Project. And I know some of you are familiar with this. I just have the one flyer, unfortunately, but you can go online to brainhealthregistry.org and find out more about it. But it's just a fascinating approach to clinical trials, because you may also know that one of the biggest expenses in research is organizing clinical and recruiting for clinical trials. And what happens is the researchers come up with this fabulous proposal for some new treatment or new drug, and then they go out and try to find the appropriate population to test it. And what Brain Health Registry is doing is signing up people right now. And you become a part of, perhaps you've heard the ads for Luminosity and some of these, brain teaser games that you can play, and they are games, but they do test brain health function and memory loss disorder, or tell you that you're perfectly healthy and have nothing to worry about. So Dr. Bernstein has been working very closely with UCSF and is bringing this research to us. So no longer will people who are curious about their brain health or struggling with memory loss disorder have to get themselves to UCSF somehow to be part of a program. They can come to Sebastopol. So we're very excited about this. And we know the need is just absolutely huge. There's 5 million Americans who have Alzheimer's, who've been diagnosed with Alzheimer's. 5.2 million Americans with PTSD. 1 in 5 Americans have experienced clinical depression or other life-affecting mood disorders, which also affects memory loss. And 1 million Americans have Parkinson's, which can also affect the memory. And it's on the rise here. We have an aging population, we know that. And we have some medication overuse with prescriptions, recreational, over-the-counter, alcohol. These things all affect our memories. And Dr. Bernstein has a whole list of things that affect our memories. The other aspect that I just wanted to touch on, I don't have very much time, evidently.
I just want to do questions.
Oh, okay, great, okay. Is that you may have heard that we are a telemedicine hub in Sebastopol, and that our medical director, Dr. Jim Good, another famous guy in the county, is running the telemedicine program. And we have a robot computer that actually finds its ways around the hall. And we access specialists all over the world. They can be brought in to diagnose a patient here that's in the Congo, for instance. We most recently hosted a team of Nigerian medical practitioners, and it was just a fabulous experience. We trained, not me, but Dr. Good trained them on the telemedicine program, And they are now bringing that back to Yenagoa, Nigeria, to their 500-bed hospital there, which serves an immense area. So it's not just Sonoma County, it's not just Sebastopol, it's really a very wide reach of services that we have now. And we're very, very proud to have them. And I can't tell you how excited I am to work with such quality people there at Sonoma West Medical. So thank you very much. If you have any questions, please ask us.
So do we have any questions? Here we go.
Yes, we'll take some questions.
Good morning. I was just part of setting up the Roanoke Park Health Center in the IT area, and I was under the impression that you guys were going to try to model yourself closer to a health center, as opposed to a strict hospital, like especially ER. You were going to try to leave Memorial and Sutter as the trauma centers. Did I get misinformed on that?
Let me clarify. We are going to be licensed as a full-service acute care hospital. Not a health center. So we will have a 24-hour per day emergency department, physicians in-house. We'll be offering an array of surgery services, as Michael talked about, orthopedic surgery, general surgery, urology, neurosurgery as well. So we do plan to provide some cutting-edge services in terms of telemedicine support, as Jane was talking about, and high-end specialty services, and emphasize outpatient services, but we're still licensed as an acute care hospital. And actually, we think that's important. One of the things that we've learned in the last several months is there's a bed shortage in Sonoma County. Maybe you've heard some of the stories we have of people that have been waiting 10 hours and 12 hours only to be transferred to another hospital outside of the area. So we are working with the other hospitals. We have a reciprocal transfer agreement with Memorial Hospital, so that if they run out of beds, they'll send patients to us. If we run out of beds or have a patient that requires services that we don't provide, we'll transfer to Memorial. But we think that there actually is a shortage of beds, and our 25 beds, I mentioned that we're licensed for 37. We plan to open 25, all of them private rooms with beautiful garden views, very nice amenities and facilities. We think that our 25 beds will actually be busy.
Questions anywhere else?
I'd just like to say that most of my friends, and I included, thought Palm Drive was cooked, that it would never come back. And this is a happy day. Congratulations. This is a wonderful, wonderful thing.
Thank you very much, sir. We appreciate that.
I don't think how are you going to prevent, how are the finances going to work this time around? How are you going to prevent history repeating itself?
So the question was, if you didn't hear it, what are we going to do differently with finances so that history won't repeat itself once again? And the answer to that is that we have analyzed the financial records of Palm Drive Hospital and feel that there's opportunity for improvement. There's opportunity for improvement in the expense areas, and we plan to run it as a business, staffing according to the required staffing levels, and certainly providing the best quality services anywhere. But one of the big differences is that we plan to not only provide all of the institute and the high-end specialty services that Michael and Jane were talking about, but market them as well. One of the big differences is that Sonoma West Medical Center needs to be able to compete with Kaiser and Sutter and Memorial, not only in Sonoma County, but outside the county as well. We plan to market the anterior approach hip replacement surgery that Michael was talking about, and Dr. Bernstein's memory loss program and neurology center. not only throughout the county, but north of us as well, into Mendocino County and Lake County, because there's a shortage of physicians and specialists up there. And we feel that we offer some of the best doctors and best services. So we're prepared to market and bring market share into West Sonoma County that's never been brought in before. The combination of the high-end specialty services, marketing them aggressively, managing our costs appropriately, we believe that we can be successful financially. Actually feel that if Palm Drive Hospital had done a few things differently, they hopefully should not have closed in the first place. We think there's a real opportunity.
Any other questions?
One more.
Thank you very much for all of your hard work. It's a huge success, I think. 5-minute wait in the emergency room. I go into the emergency room, and within the 5 minutes, what's the next step? Does that mean just that I'm acknowledged, or I'm already having a diagnostic test done?
I'll explain. So the 5-minute wait time in the emergency department is not just speculation or a goal or something that we hope will happen. It's actually been proven that it can happen. The medical staff, the emergency department medical staff that we've brought into our emergency department is headed by Dr. Rodney Look. Dr. Rodney Look is the emergency medical director at the St. Helena Hospital in the Napa County, as well as the emergency director of the St. Helena Clear Lake Hospital in Lake County. And his emergency room doctors, who he's handpicked for their diagnostic skills and board certification, experience, and qualifications, are trained to diagnose quickly. So what you will find when you come to the emergency department at Sonoma West Medical Center is that we will take you back immediately. We have expanded the footprint of our emergency department with an observation area, a 3-bed observation area that wasn't part of the hospital or the emergency department in the past. So that we will always have a bed available. Our goal is to always have a bed available in the emergency department so that if you come in and need to be seen by a doctor, you'll be taken back right away. Within the first 5 minutes, not only will you be put in a bed, but you will see a doctor, and the doctor will start treatment. He or she will examine you, will begin a diagnosis, will begin ordering tests. If it appears that you're going to require a lengthy observation, and you may be moved into that 3-bed observation area, which is right across the hall from the emergency department, where there will be a nurse that will be staffing that area, so those patients will be under observation. And then you will either be sent home, or perhaps admitted to the facility, or perhaps transferred to another facility. But Dr. Look has been very successful in creating this type of rapid diagnosis process with the entire team, so that waiting times we anticipate will be minimal.
Thank you.
You're welcome. Can I just do a real quick commercial? In my last couple of minutes, I want to tell you about something that we're doing at the hospital. It's a lot of fun for us. We're part of the community, and we want to be part of the community. We've entered into a national competition called the Medline Pink Glove Dance Video Contest. So we invite all of you, everybody in the county, everybody in the country, to vote for Sonoma West Medical Foundation for best video, and if we're successful, all of the proceeds go for breast cancer research, breast cancer education, treatment, and prevention. What that's all about is the company and you can vote at www.pinkglovedance.com and look for Sonoma West Medical Foundation under the non-health organizations. The reason we're listed under non-health organizations is because when we entered, we weren't a hospital yet. We're still not a hospital yet. The Pink Glove Dance is all about breast cancer research and awareness. Medline, the company that sells our surgical gloves for the month of October, Breast Cancer Awareness Month, distributes pink surgical gloves. Hospitals all over the country break out the pink gloves, create a music video, enter a contest, and the winners can win up to $15,000 for breast cancer research and education. We are currently 3rd place in our division. You can vote every single day until September 23rd. 1 vote per day, per email address. If you're sneaky like me, I have about 8 different email addresses. I'm voting 8 times a day. We have about 1,500 votes. We're in 3rd place, and we'd love for you to watch our video and vote for us.
The website once more time.
www.pinkglovedance.com.
Thanks, how about a big round of applause?